to our monthly scientific session. Hope all of you are doing good and fine. Stay safe and blessed. Okay, so today we are very lucky to have a join from our profession to deliver the talk. Let's welcome Dr. Giridhar Anantharaman, Chief of Pituitary Surgeon and Chief Pituitary Surgeon at Giridhar Eye Institute, Kochi. Warm welcome, sir, from the KOS family. And to chair our program, chair the session, we have with us Dr. Prakash, Head of Pituitary Services, Complex Eye Hospital. Welcome, Dr. Prakash. And now let me invite Dr. Divya.
Thank you.
Divya Nair, she's a consultant pituitary surgeon at Trinity Eye Hospital, Kozhikode. Welcome, Divya.
Thank you, ma'am.
Yeah. Once again, welcome all. And now let me invite Sujit. Thank you all. Sujit.
Thank you, madam. Welcome all once again for our monthly meeting of July. It's a privilege to have Dr. Giridhar sir for our meeting. He had promised us last month and was unable to do it. So thank you for being with us today, sir. And there's nothing much more than common things to say. We'll directly go to the academic meeting. Let me invite Dr. Divya to formally introduce our speaker for today.
Thank you, sir. It is my honor and privilege to introduce the speaker for today, who is a stalwart in the field of ophthalmology and retina, Dr. Giridhar Anantharaman. Dr. Giridhar sir is presently founder medical director and chief mentor at Giridhar Eye Institute, a tertiary referral eye center at Cochin, Kerala. He is trained at Jipmer Pondicherry and Shankar Nethralaya, Chennai. He is a senior vitreoretinal surgeon with over 3 decades of experience. He was a past president of the Vitreoretinal Society of India. He has received achievement awards from the Asia Pacific Academy of Ophthalmology and the American Society of Retina Specialists. He is a key opinion leader in vitreoretinal diseases in India. He has made over 250 lectures in national and international forums, and he has over 65 publications in peer-reviewed journals. His areas of special interest include diabetic retinopathy and macular diseases. Over to you, sir.
So, yes. Okay, thank you all. I mean, thanks for the invitation. Am I audible?
Yes, sir, you're audible, sir.
Okay, thanks a lot for the introduction. I mean, I'm no new face, so I don't think it has need to be introduced at all. So, anyhow, it's nice to see at least the faces of some of our senior ophthalmologists and colleagues. I mean, Dr. Prakash and Dr. Divya Nair, isn't it?
Yes, sir.
Yes, okay. It's a very common name. This Divya is so common in Kerala, anyhow.
In retina, more common.
So, I mean, I chose to talk on diabetic. Actually, initially, I gave another topic to Dr. Nayanar and then finally changed it because I thought I may end up in a lot of controversies. Anyhow, I thought I'll talk on diabetic retinopathy because I think a large percentage of patients who are now in the retina clinic, at least I think about 50% of patients who come to retina clinic, I think it is diabetic retinopathy. I really don't know what's the trend in other parts of India, but at least in Kerala, and that trend is only increasing. That is, we see more and more patients with that. So I think from the point of view of a comprehensive ophthalmologist, and also from the point of view of medical retina specialists, I think this is a very, very important, very important to at least know and about screening for diabetic retinopathy, detection of sight-threatening diabetic retinopathy, because there are so many models for screening and detection of diabetic retinopathy. But I think the most important point that we should know is we should screen the vulnerable population. I think if you are not screening the vulnerable population, you are not going to detect diabetic retinopathy. There is no use conducting eye cams to detect diabetic retinopathy. There is no use of just amassing about 100 people with diabetes and trying to detect diabetic retinopathy, because there is a vulnerable population among diabetics who are more susceptible to diabetic retinopathy. So there's a lot of work that's going on in that direction. And probably screening techniques should all evolve in such a way that we don't miss these sort of patients who probably need treatment. And rather than wasting a lot of time trying to see patients with 1 year of diabetes, 2 years of diabetes, who may not have any diabetic retinopathy at all. So what I'm going to talk is on some recent concepts in imaging. And the reason why I am talking is we have been working on this in this particular area for the last about 1.5, 2 years ever since, and especially in the after the COVID pandemic. Somehow, I have been seeing some of these patients and doing these sort of tests, and I have learned quite a lot. I mean, and based on what I learned, we did some work, and I thought all this will be quite useful for ophthalmologists in general. At least it may be an eye opener for many of you practicing ophthalmology. So I have no financial interest because we are talking about machines and equipments and methodologies with machines. So I have no financial interest. So my flow of presentation is basically on 3 aspects of imaging. One is the wide field retinal photography. The second thing is fundus fluorescein angiography, and a little bit on wide field OCT, because there is again a lot of innovations when it comes to wide field OCT, and some of my younger colleagues in the department also have experimented with some of these innovations in wide field imaging. So I thought I'll just share with you some of these information. So actually, it's exactly 100 years since Carl Zeiss developed the first fundus camera with which we could photograph the retina. It's exactly 1926 was when Carl Zeiss took the first retinal photograph, and today we are in nearly 2021. So it's about 100 years. And there's a lot of improvement, of course. Initially, it was a 20-degree photograph, then it became a 30-degree photograph, and then became a 50-degree photograph. But then with the conventional fundus cameras, we are only photographing a very small miniature portion of the retina, and the larger portion of the retina probably is only being examined and not photographed. I would like to say that in the evaluation of any patient with diabetic retinopathy, photography is very, very important. It is important for 3 important, it serves 3 important purposes. One is, it is good to document, because if you want your patient to come back to you, you're not going to really remember what you have seen earlier. So when the patient comes back, you can take another photograph after 1 year. You see the changes and you know whether it's getting better, it's getting worse, whether new changes are there, etc. Number 2 is very good for patient education. And number 3 is that it is very good for for research purposes. So these are the 3 important reasons why. Therefore, when a patient with diabetic retinopathy comes to a clinic, and if you are having a medical retina center where you've got facilities for OCT, angiography, and photography, I think it is mandatory that we do photography. Therefore, in cases where there's mild changes, you just do a photography. And other cases where you have to force to do the other tests like OCT and angio, you can go ahead. So photography is an important part of the evaluation of any patient with diabetic retinopathy. So, so I'm just showing you the further development. So after the early fundus images, we got what is known as this montage imaging, where we take multiple photographs of the retina and try to combine them into one. And this is a very tedious process. Now, unless you have professional retinal photographers like what we have in our hospital, who sit down and take these sort of pictures, it's not an easy thing. And therefore, we often forego these sort of examinations. because we don't have the time to do that. So we are left with multiple images of the posterior pole, where we may take one picture like this with the disc in the macula, one picture with the disc in the center, so that we get, another about 30 degrees or 35 degrees all across. So now, conventional teaching as far as diabetic retinopathy is concerned is that it's mainly a posterior disease. Actually, when I was a medical student and also as a postgraduate student, and also probably when I was doing my retinal training way back about the early 80s, actually the basic teaching was that in a diabetic retinopathy, you see this particular area, and then if it is in Eales disease, you see the peripheral retina, because Eales causes peripheral neovascularization and peripheral proliferative tissue. So that was a conventional teaching. And therefore, even when I used to do a biomicroscopic examination of retina in the retina department, even when I was doing my practice here many years ago, is that when I put the patient in a dilated pupil on the slit lamp, I see this particular area, I see here, I see here, I see here. Because if I don't see anything much in any of these areas, I'm quite convinced that probably there is no evidence of any retinal neovascularization or a sight-threatening retinopathy in an otherwise patient with a normal visual acuity. So unfortunately, a lot of things have changed since then. So if you look at this montage picture, you see changes here quite far away from the disc. Here you see retinal hemorrhages, and here you see some lesions here. So basically here, right here, you're seeing some lesions. Therefore, if you're seeing lesions much beyond areas probably, which we normally don't examine in a dilated pupil with a slit lamp, and probably we may examine with an indirect ophthalmoscope, but then magnification definitely is reduced, and neovascularization can be often missed in indirect ophthalmoscopy compared to other forms of examination. So this is the montage for you, and this is the wide angle one picture using the new systems for wide angle photography, where with one shot you get the complete picture of the retina. So, of late, there has been a classification of the wide field and ultra wide field imaging. And basically, because there are a lot of definitions that have been going on. So the international group has now come with a consensus definition where they have used anatomic landmarks in the retina to define what is wide field and what is ultra wide field. Therefore, the posterior pole is the retina within the major temporal vascular arcades or just beyond. And up to the vortex edge of the posterior edge of the vortex ampulla is the wide field. And beyond that, to the periphery is the ultra wide field fundus imaging. So these are the two important areas, wide field and ultra wide field. And ultra wide field can go anything between 105, 110 to more than 200 degrees. So what are the commercially available wide field imaging systems? The commercially available wide field imaging system includes the Optos, the Heidelberg Spectralis, the Claris, and also the contact lens developed by Staurengi, and the RedCam, which is primarily used for retinopathy prematurity screening and also documentation. So the Optos actually is what we have been using now for the last 2 years, and we have been using it purely on the basis of a research purpose to collect data on diabetic retinopathy and try and do some studies in Indian population. And in fact, we tried to collaborate and get one machine for one of the other hospitals in northern Kerala. But unfortunately, because of the COVID pandemic, I think it's become very, very difficult to do that. Because what I was looking at is to look at a very diverse population in Kerala, because our center probably does not get that many patients from northern end of the state, but mainly from central and southern Kerala. So I was just looking whether we can look at the wide, diverse population in the state of Kerala. So the Optos is a multimodal imaging tool. It's got high resolution. It actually uses the SLO technology, and it causes pseudo-color images. And it has got an ellipsoid mirror, with which it's able to, take this picture. Actually, it's very simple. It just takes a few seconds. You just have to keep your eye and focus on the aiming point, and then you can easily take the picture. So it's a very simple method, and it is a non-mydriatic. Even without any dilatation, you get good images. So it's taking about 82% of the total area. And most importantly, once you acquire the image, you can zoom it. So you can enlarge it, you can change the contrast. So you're able to really see subtle lesions in the retina. And that's what probably makes it really a very useful tool, especially when it comes to diabetic retinopathy. So there are various types of Optos devices where the basic device is what we are having, basically Daytona, which has got the color and the autofluorescence. Of course, they have tools with which you can do the other imaging techniques like fluorescein ICG, and also the most recent, the Monaco, which has got the OCT, all very, very expensive machines, probably, which is not really possible to have in our forms of setup. So I thought I'll just give an overview of the clinical application in diabetic retinopathy and what's important. So this is the picture that I showed you earlier. And the basic idea of showing this picture is just to show you the difference between what we see in a montage and what we see in an Optos image. And you can really appreciate that the area of coverage is far more than what we see in a montage image. So for many years, right from 1991, our understanding of the severity of the diabetic retinopathy, the diabetic retinopathy severity scale, the classification of diabetic retinopathy, etc., is based on the standard ETDRS 7-field fundus photo. But then you will all agree with me that in clinical practice, we hardly do this sort of an examination. We really don't spend that much of time taking so many images to study the exact, the 7-field fundus photography. So it's a tedious process. And if you put this, overlay this ETDRS grid onto an Optos image, you can really see that with the ETDRS, we are only examining this portion of the retina, but we are not examining the rest of the retina, which is also susceptible in diabetic retinopathy. And recently, there has been a lot of interest in the peripheral retinal lesions in diabetic retinopathy, which I'll come to later. And this is the gentleman who's done a lot of work in this Silva. And he has shown that in a particular paper, which was published very recently, that possibly the presence of PPL is an indicator of a higher risk of progressing to proliferative diabetic retinopathy. What I'm trying to evaluate now is to find out whether PPL is more common in patients with comorbidities like nephropathy, and other vascular comorbidities in diabetes, whether and younger diabetes, etc. So because I personally feel that these are the sort of patients who are the vulnerable population as far as development of diabetic retinopathy is concerned, and whether the presence of PPL can be used as a biomarker, as an important indicator that yes, these patients may progress into nephropathy. Persons like Dr. Prakash will agree that many of our patients with proliferative diabetic retinopathy who do not have much of renal disease initially do progress into renal failure over a period of time. So this is an Optos image for you of a patient in our clinic with a treatment named PDR with good visual acuity. And if you see the Optos image and zoom it and see the magnified image, you can see the subtle areas of neovascularization. And also you can see this ischemic, whether the occluded retinal vessel, and the same is of course seen in fundus fluorescein angiography. Therefore, what we see in a carefully examined Optos image is more or less mimicking what we are seeing in fundus fluorescein angiography. Therefore, that's a level of resolution. And therefore, I felt that it was a very useful tool in patients with diabetes, especially for a screening tool in a vulnerable population. And therefore, the reason why I got this interest is in the early part of the pandemic, when we were really confused as to whether we can go ahead with fluorescein angiography, etc. Photography formed a very important method of retinal examination. And I realized that really with the Optos, we could do a lot of good work by diagnosing sight-threatening diabetic retinopathy, which would have otherwise been missed if not for a fluorescein angiography. So this is another picture to show you that this is the area that we would normally examine or photograph in a normal fundus camera. But then in this particular patient with diabetic retinopathy, you can see that the peripheral retinal ischemia is very evident even in photography. And surprisingly, if you see the fluorescein angiography, a picture which we normally don't see in diabetic retinopathy, but this is a patient with chronic diabetes, nephropathy, etc., who's having totally occluded vessels right from the equator to the ora serrata, just to tell you that peripheral ischemia is a very important element in diabetic retinopathy, unlike what has been taught in earlier years. So with this introduction, actually, we did this study to assess the sensitivity and specificity of sclerocular ultra-wide field imaging in comparison to wide field fundus fluorescein angiography, because this is the gold standard. So I thought that we will compare the ultra-wide field image, photo image, with the wide field FFA in detecting retinal neovascularization in diabetic retinopathy. And this may be a very important message that we can give to at least the teams that are working on screening techniques for diabetic retinopathy. This paper, incidentally, was just accepted in the British Journal just about 2 days ago. So actually, this is the gold standard, and this is the pseudo color. This was although this can be done with the undilated pupil, in our study we have used it with a mydriatic eye, and both the tests were done on the same day for these patients. So the hypothesis on which we were working was that pseudo-color retinal imaging is as accurate as standard FFA to robustly detect PDA in people with diabetes. And therefore, this is basically a diagnostic accuracy test and to detect NVE and, if possible, NVD. So we had about 176 eyes of 94 subjects, and this study was done between January 2019 to 2020. And basically, we looked into mainly eyes with severe non-proliferative diabetic retinopathy. That is, in the outpatient department, the ophthalmologist or the retina specialist, after seeing the patient, puts a diagnosis of severe non-proliferative diabetic retinopathy and sends the patient to the imaging room for further tests of fluorescein angiography and photography. And also patients, and just looked into how many, some of these eyes actually are early PDA. And also the other group was the early proliferative, because these are the two important groups that we were looking into, because these are the two important groups where the patients may have normal visual acuity and sight-threatening retinopathy. So this is the index test, and this is the reference test using the Optos data and the Heidelberg system. Now, as far as our study is concerned, of course, we don't have the Optos fundus fluorescein angiography machine. Therefore, we have used the Heidelberg, which is only a 102-degree image, compared to the Optos, which is a 200-degree image. Therefore, that was probably one of the weaknesses in our study. Therefore, we used the recommendation from the International Wide Field Imaging Study Group, where we bisect the fovea and divide the retina into 4 quadrants for purposes of what you call documentation: upper temporal, upper nasal, lower temporal, lower nasal, like that. So actually, this is a beautiful photograph to show you, how beautifully you can see small areas of retinal neovascularization in using this photographic technique. And you can see these small, and then these small areas of neovascularization actually correspond to areas of correspond to areas of leakage in fluorescein angiography. Therefore, it's quite a sensitive technique, actually, when you see that. And moreover, you can see here that some of these areas are quite peripheral as far as the documentation is concerned. Therefore, the technique is, the sensitivity of, based on these sort of, based on this particular photograph is very, very good. So we had 2 independent masked investigators. Actually, one looked at the photograph. They did not have any access to the EMR records at all. They had only access to the one had access to the photographs in the machine, that is the Optos machine, and the other had the access to the Heidelberg imaging system, and where he was looking into the fluorescein angiography. So we had 2 independent investigators, masked investigators, who looked into this data, and discrepancies were settled by a principal investigator. So So this is, just to show you, how important peripheral ischemia is in diabetic retinopathy. Now, if you can see in this particular photograph here, you see areas of neovascularization, which are probably just very near the equatorial area. And if you see the fluorescein angiography, you hardly see any ischemia, not much of ischemia here in the posterior pole and the 45 degrees or 50 degrees retina. But then there's so much of ischemia in the retinal periphery. And this again is an important indicator to tell us, yes, that peripheral ischemia is an important ingredient in diabetic retinopathy, at least in select group of cases. So this is just to show you how you're able to discern the the distribution of the neovascular network. You can see in this particular case is purely in the nasal quadrant. The temporal quadrant hardly shows much of changes here. And this again corresponds very beautifully with the fluorescein angiogram that we are seeing here. This is another case where again, the opposite side, the opposite nasal quadrant, you can see these areas, and of course, these are quite large and quite easily visible, but not the small areas of neovascularization that I showed you in the first slide on this particular paper. So we divided the eyes into these three groups, and we calculated the sensitivity and the specificity, the positive to predictive value, negative, etc. in each quadrant, and we found that the sensitivity and the specificity of the color photography to detect was reasonably good in every quadrant as far as each of the quadrants is concerned. And we also looked at the total, all quadrants put together also. And we also did the inter-observer agreement, kappa inter-observer agreement, which is quite good. So the sensitivity over, you can see here 82.5 and 86.5, which is quite good to detect neovascularization. Therefore, overall sensitivity was about 92.5 and specificity was 81%. Therefore, pseudo-color ultra-wide field imaging had excellent sensitivity and reasonable specimen compared to wide field fluorescein angiography, and is an effective tool in detecting neovascularization in diabetic retinopathy. And this increased sensitivity is very important, especially when it comes to patients with severe non-proliferative diabetic retinopathy or suspicious early proliferative diabetic retinopathy, because it has got a lot of clinical relevance. So basically the take-home message, I think, as far as this particular study is concerned, is that probably these are tools which can be installed in centers which treats a high volume of diabetes patients. Like, for example, the Mohan's Eye Hospital, Diabetes Center in Chennai has got this machine. So these are centers which have got a high volume diabetes patients, and these are hospitals which definitely can invest in these sort of equipments. And probably if you have even a tie-up, a telemedicine tie-up, an eye hospital has got a telemedicine tie-up with these sort of centers, you can do the reading of these images, and definitely that will go a long way in detecting treatable diabetic retinopathy. As a corollary to that, actually, as I was preparing this, this part of this talk I had given recently in an international diabetes meeting conducted by a diabetes hospital in central India. And actually, as I was preparing, I found this particular paper as to remote screening of diabetic retinopathy using, and this has been done in Japan. Of course, it's a very developed country. They have all the infrastructure and the economics to get these sort of equipments. And I'm sure there are centers in our country also which can really have these sort of facilities. So what they did in Nagoya is that, in Japan, is that in the Nagoya City University, in the Department of Internal Medicine, they installed the Optos Daytona. And basically, this was connected through cloud to the retina department of the Nagoya University. And all the images were actually forwarded there. And they could detect a sizable number of patients with diabetic retinopathy using this remote interpretation technique, using the ultra-wide field retinal imaging. Because this is far superior to conventional techniques using indirect ophthalmoscopy or the smart fundus cameras that we have, which really only documents a very small portion of the retina. Therefore, that may be okay, that may be fine for the sort of screening camps and other techniques, but definitely in vulnerable population, these equipments have got a very, very significant role to play. After this, I would like to just say a few words about the importance of or the relevance of ultra-wide field angiography in detecting the classification of diabetic retinopathy. Because unfortunately, unless and until we do these sort of techniques of examination, we really do not know as to what we are missing or what is the application. So that's where, that's the whole crux of the issue. So it's like, when OCT came into clinical practice in ophthalmology, little did we believe that, 10 years, 15 years down the line, every eye clinic will be having an OCT machine. So it's not just for the purpose of having the machine, but then most ophthalmologists feel that this has become an integral necessity in a part of a routine ophthalmology setup. So similarly, once ultra wide field fundus angiogram, it is able to detect much more areas of perfusion. It's able to detect much more areas of neovascularization, and you're able to give much more areas of panretinal photocoagulation, and it helps in what I call the targeted laser photocoagulation. For example, the patient that I showed you in one of the cases there, where all the ischemia is beyond the posterior pole, there's no use giving aggressive laser close to the optic disc. It's only necessary in that particular area where there is significant ischemia. So all these techniques definitely have improved our understanding, improved our methodology of treatment. And you can see in this particular case here, where the ischemia is right in the periphery. Therefore, it does happen. Therefore, this is a case from that particular paper that has been, that I showed you. And if you see here, what they have put is they have put the overlay of the ETDRS 7-field grid here. And you can see some of the areas of ischemia, which is going much, much beyond that. Just to tell you that earlier teaching that you don't have to give laser to the periphery, it doesn't really hold true. And probably one of the reasons why some of our patients don't respond to treatment with laser photocoagulation is we are not really treating the ischemic retina. We are only treating we are just treating PDR the way we were treating PDR with laser 25 years ago. And our concepts have changed, and we need to change the way we treat these patients. So a word or two on peripheral retinal lesions. So basically, this is all these papers, 2 or 3 papers by Silva, where he has shown that this is a particular paper where he has followed up patients, and he has shown that possibly there is a risk of progression over a period of 3, significant risk of progression and peripheral retinal. What are these? I'll just define what are these PPLs, what is PCL, etc. with another slide. But then this is a very important message. Now, I really do not know because there is only one study from India. So we do not have much data from India as to what percentage of patients with diabetic retinopathy have peripheral retinal lesions. And basically, we have to look at from centers who are having a large number of patients with diabetic retinopathy. So this is how you define the peripheral field. So the ETDRS 7-field overlay is placed on the Optos. This is a facility that the Optos Daytona has, where you can just put the ETDRS overlay onto the image, and then you divide this into this many, the peripheral fields. There's 1, 2, 3, 4, and 5. And basically what you're doing is you're comparing each peripheral field with the ETDRS central field, that particular quadrant. Therefore, when you say predominantly peripheral lesion, is that more than 50% of a particular lesion is in the peripheral field, then you call it predominantly peripheral lesions. Yeah, if it is more than 50% is within the ETDR, as you say, it's predominantly central lesions. And therefore, that's how you say whether lesions are predominantly peripheral or predominantly central. And you need, it's quite a tedious process. You need to sit with the machine, count the number of hemorrhages that are there, count the number of cortical spots that are there, and also areas of neovascularization that is there, to really document this particular change. So this is the original paper by Silva, which was published, I think, in 2019, or 2018, where he has shown that nearly 30% of patients with diabetic retinopathy do have peripheral retinal lesions. So this is a very important take-home message, especially in understanding diabetic retinopathy. So this is the only study, actually, there's a multi-centric study from India, which was published very recently, end of 2020. This is from the major institutions in India. They work together, I think, using the SATA group and the Optos imaging system. And here they have written that the lesion distribution was rated to be PPL in 37% of eyes and PCL in 63%. About 30% of eyes with diabetic retinopathy do have peripheral lesions. A few words on peripheral neovascularization in diabetic retinopathy. Now, if you put this ETDRS grid here onto this particular image, color photo image, you can see that a sizable number of neovascular tufts are beyond this ETDRS grid. Therefore, you do see areas of retinal neovascularization. There is one here, there is one here. So you do see areas of retinal neovascularization outside the ETDRS grid, and therefore you need to look for these subtle changes when you do a clinical examination on your patients. So this is again another case to just show you. These are all treatment patients with normal visual acuity. So some of the other applications of photography, especially wide field, is that you can do targeted laser, and after doing the targeted laser, you can take a photograph and check whether the areas of ischemia have been adequately covered. And as you can see in this particular, this got some artifacts here. And also post-operatively in PDR surgery, especially in patients with silicone oil, you can take a photograph before SOR, silicone oil removal, just to see whether the retina is very well attached everywhere and your treatment has been good, so that it's much safer to remove the oil. Of course, these are all, not really, what you call necessary techniques, but definitely quite useful in clinical practice as far as documentation and also decision to treat is concerned. So in summary, as far as the ultra wide field photography and angiography is concerned, it definitely has an important role in screening and detecting and management of sight-threatening diabetic retinopathy. Unfortunately, the cost of equipment is the main issue, but then it can be utilized in settings with high volume of diabetes patients and diabetic retinopathy patients. And basically, definitely, it's going to improve the quality of work that you do. It also improves the outcomes of patients that you treat. I would like to give acknowledgement to Nikon, who is now dealing with the Optos machine, for kind enough to give us this equipment for a period of 2 years. Mr. Rakesh, who is the photographer, who's done stupendous work, and also some of our fellows who have been working with us for the last 2.5 years. I would like to say a few words on wide field OCT imaging. I wrote a small article for the Indian Journal of Ophthalmology as a commentary for another article that was published on wide field imaging, which where I looked into the various techniques of wide field imaging. Of course, the Sepsos OCT gives you a 12 into 12 mm scan, again, a very expensive machine. We are using the Heidelberg 55-degree lens. I'll show you the images later. It gives an area only beyond the vascular arcade. It's good in patients with diabetic, especially surgical cases with diabetic retinopathy, traction retinal detachment, and taut posterior hyaloid. You can take multiple pictures, and at least it tells you areas of separation of the hyaloid from the white vitreocysis from the retina. It's quite useful. Okay, so conventional scans actually take 9416 by 9437 horizontal and vertical. Sepsor is about 12 millimeter. And some of the innovations are, of course, the montage imaging and the use of the 20D lens. Actually, you can put the 20D lens in a trial frame. It increases scan width to about 13, 16, 10. So it's quite a wide scan you can get with a 20D lens. This actually one of my old fellows used to do on a regular basis in interesting cases. And you need people who are really interested to do all this, because they all take a little time. It's, all innovations as far as which saves a lot of cost, but then it requires a lot of effort and training as far as the techniques are concerned. So this is the Heidelberg 55-degree lens. I've written percentage, sorry. So you can see here, this is the area that you get, but then you can see these areas of separation, etc., which are quite visible. And that gives you an idea, as at least intraoperatively, maybe of some help to you as far as the surgical technique is concerned. So this is a recent paper for which we wrote the commentary. This is from the Shankara group in Bangalore, where they have used another technique where they have used a 90D lens. The 90D lens is brought very close to the eye, and the imaging device is brought very close to the 90D lens. And I think if I'm not mistaken, I think the imaging is done using you can get about a 9 millimeter or a 10 millimeter scan in this particular technique. So this is, again, the scan pictures were quite good actually in this particular article, but again, it requires little experience. You need a very clear media to do this. If there are cataract, if the pupillary dilatation is poor, etc., it's not easy. It's quite a difficult task. But then they have compared this with the Sepsos OCT, and they have shown that the sensitivity and specificity is reasonably good. So this is another picture from the same paper to show you that it can really goes up to the equator. You can see it's quite a wide scan that you get with this particular technique. They're using a 90D lens in front of the eye, keeping it very close to the eye. So this is a paper which one of my old fellows, actually, I cannot take any credit for this because it's a work that he himself did. This guy was really very much interested in imaging and he used to sit with the machine and do all this. So he did what is known as a montage picture of the OCT, and he was able to really bring I mean, you can see here how beautifully he has been able to. This has come as a cover photo in the Indian Journal of Ophthalmology a couple of years ago. So basically, we are now looking at a new diabetic. Actually, there is something called the diabetic retinopathy, a new study being conducted now by the DRCR, what is known as the DRCR 7AA trial, which is now looking into all these aspects on wide field imaging, the diabetic retinopathy severity scale assessment using wide field imaging, and whether we need to really change our classification based on wide field retinal imaging in diabetic retinopathy. And there are 4 or 5 things that they are looking into, and probably within 1 or 2 years or 2 or 3 years, we'll have the answer to that. So imaging definitely is an integral part in the management of DR, and wide field imaging definitely, I feel, will improve outcomes, at least in select patients with sight-threatening diabetic retinopathy. And of course, the limitations is the high cost of the equipment. So thank you all for your kind attention, and thank you for the invitation. And I hope that this talk was quite interesting for all of you.
Thank you very much, sir. Thank you very much for this wonderful and informative talk on wide field imaging. And I'm sure we have a lot of lessons to take from here, that when we have patients who are not willing to go for a dilated fundus examination, especially who are chronic diabetics, I think this would be a good option for them, and they need not have a dilated examination regularly, because when we send them back, they may not be coming to us and they may present in some very advanced diabetic stage. Sir, what are your thoughts on this targeted laser photocoagulation for recalcitrant diabetic macular edema?
Yes, ischemic retina. Ischemic retina.
Yes, sir. Because when we give 2 or 3 intravitreal injections and then the diabetic edema doesn't seem to resolve.
Yeah, I do targeted laser to ischemic retina in patients with diabetic macular edema who are not responding very well to anti-VEGF injections. Okay. I do it even in patients with venous occlusion, branch venous occlusion, especially, where there is significant ischemia. I mean, the patient is already receiving injections nearly every other month. So after 3 or 4 injections, I usually do a fluorescein angiogram, advise the patient in FFA, and if there is significant ischemia, I use it as because there's no harm. There's no harm in doing it. It's not going to worsen the edema, and that's probably another method by which we can treat. And there is some scientific basis on that, because laser can reduce the VEGF levels. It may not reduce the inflammatory cytokines. I don't know whether it reduces the inflammatory cytokines, but definitely it reduces the VEGF levels. And that may, to a certain extent, but that effect comes much later. You don't see the effect coming in 1 month or 2 months. When we give laser, I think we need to wait. We need to wait 6 months, 8 months for it to work. It's not that, so that's one thing which we have to tell patients, that when we give these targeted lasers, I think especially in these sort of clinical situations, we have to tell them that laser takes time. So in the interim phase, there may be a need for a couple of more injections. So it's not that you combine the two, that within a month or 2, you're going to get the result. Yes, Prakash, anything you want to say?
It was a wonderful talk. You told at the beginning that it is going to be an eye-opener for general ophthalmologists, but it actually happened to be an ultra-wide eye-opener for all of us, actually.
I tried to get that machine for your hospital, but
yes, sir. Unfortunately, I think the COVID. I was actually communicating with them, but they told due to COVID they cannot send it now.
Yeah.
We had completed all the formalities. Actually,
I know. They had completed. So basically, I mean, anyway, we'll see after 6 months, 8 months. I don't know whether it's possible, but it will be
by
nice.
that time, study may be over.
No, but if see, the thing is that these companies, if you're using the machine properly and if you're bringing out some good results, they don't mind keeping the machine,
Yes, sir.
So
Yes,
if
sir.
they're just idling there and they're just taking photograph and you're just trying to make some money out of it, then
Yeah.
they will take it off. But then
Yeah.
you're producing some results.
Yeah, it was wonderful that you could produce a paper out of that.
Yeah.
By
No,
this
we're
time.
working on a second project, which probably by the end of the year, we may be able to, another 3-4 months. That is the second project where we wanted you all to collaborate, but
Okay.
it didn't happen. But now we are having the Mohan Center is working with us. So because that lady, she's very good. Rajalakshmi, she's
Okay.
a medical retina specialist in Mohan's place in Chennai. She is a very smart lady, very capable. So she is working with us. So
Okay.
the cost of the Daytona, I think, is about 85 lakhs. Someone is asking the Daytona.
Yeah,
That is just the basic photography with autofluorescence itself is 85 lakhs.
Sir, do you think?
Yeah. Yes. Yeah. Tell me.
Do you think can we at the beginning itself, if somebody is starting a retina clinic, instead of a conventional photography, conventional fundus imaging system, can they go straight away with ultra wide imaging?
Yeah.
Does it have any lacune compared to our?
I don't think so, because even macula is seen well, because you can zoom the macula and examine it. So you are not going to miss anything. You're not going to miss anything in that image. Even your macula, you can see very well. Probably macula, we have got used to seeing the small photographs, so we have got habituated to that. But I think even the macula, if you just zoom that area, you are not going to miss any lesion. So small subretinal hemorrhage, everything you're going to see. So everything you're going to see.
In diabetic retinopathy, sir, is there any situation where you will straight away go out for an ultra wide imaging rather than angiography with the machine you have, that's a Heidelberg?
No, here in our hospital, now all patients with diabetic retinopathy, we are doing this wide field angiography only.
Angiography only.
Yeah, we are not doing all vascular diseases, BRVO, CRVO, diabetic retinopathy. We are using the Heidelberg 102-degree lens and doing it. Yeah, because definitely it is giving us much more information than what we get from the conventional thing. So in the mid phase and the late phase, they will take that full image. So you can just see whether there are any neovascularization also, and also the extent of ischemia is seen, how much it is extending into the periphery. So the laser can be given better also in these sort of situations.
Sir, does the Optos work well with media opacities?
No, cataract is an impediment. You can see, but it definitely is an impediment. Cataract is definitely an impediment. But mild cataract, no problem. It is very good in small pupil. See, if, for example, now you have done a VR surgery, pupil is not at all dilating, oil is there, and you are not able to see the retina, you don't have to struggle. With that small pupil and this thing, you get beautiful picture. So in a non-mydriatic situation where, there is not much of media like thick PC or anything like that, you can get a very good picture. So only that cataract, that cataract haze will come in the middle like that. It will be seen. But otherwise, it's a small pupil, it is beautiful. Actually, last month when I was talking, one of the panelists was saying, I didn't realize that. I have used it in one or two of my patients after surgery. Pupil is not dilating, struggling like this. You just send it there, it just gives you the full.
Sir, in peripheral PCVs, the peripheral hemorrhagic exudative chorioretinopathy, do you pick up lesions on ICG in those cases?
Yeah.
The vascular complexes.
Wide field ICG, we are able to get the polyps. Yeah, we are getting the polyps. Wide field ICG. If you're hiding the Heidelberg system, I feel you can get the 55-degree lens. Yeah, you can get the 55-degree lens. If you're having the Heidelberg imaging system, you can get the 55-degree lens. It will be a very useful this thing. In any high volume retina setup, it is really worth it. Yeah.
So since we are with the topic of diabetic retinopathy, it is not related to imaging, but what is your thought process about protocol S? Because we all have been going around with PRP lasers and
PRP is still the gold standard. Actually, even recently that international survey, most of the people are doing PRP only. So PRP is still the gold standard, because when we give an anti-VEGF alone, you need to have your patients coming back regularly.
Strict follow-up.
Strict follow-up. They are not going to come. There is going to. Actually, we have a nice case report which we have put in AJO case report a couple of years back. That was done by my old fellow Jai Sheth, where we have shown in a patient, actually one of my patients only, I gave injection, I did angio, I gave injection, I took one angio immediately 1 month later, beautifully everything gone. And again, 3 months later, the patient came, I repeated, everything has come back. So, and it's completely, again, all that area has come. So, the thing is that beautiful documentation. So, you have to keep on giving injections. So, but then I personally feel, I don't have any data, what you call to collaborate that. But I personally feel in patients with, say, a florid NV in the disc, but no fibrous tissue. Sometimes we see not only blood vessels. Those sort of cases, when we give laser, we are very sure that the neovascular network is not going to regress much. So we can give along with that one shot of anti-VEGF, not multiple shots. So I give like that. Or just frank NVEs are there, no fibrous tissue, but frank NVEs are there. I combine laser with injection. One shot of injection I give. I don't have any evidence to say, but then I have seen after 6 months, 1 year, in these sort of disc NV cases, the disc NV has not come back. There are 2 or 3 vessels, few vessels, but definitely it is working. So those sort of situations where there is no fibrous tissue, but a lot of surface neovascularization, which is quite large, and it is unlikely to regress significantly with the laser alone, probably there is a value in giving this thing. It's each person in my hospital, I think only I am doing it. My three of my colleagues, I don't think they are doing it. But basically, there is a difference of opinion as far as these things are concerned. But I think in these sort of very select group of patients, I think we can give one shot of anti-VEGF along with laser photocoagulation. You agree with me, Prakash? I think that is we can give that. Yeah.
Do we have any other questions for sir?
It is too much, very highly retina. That is the problem. It is like, today I had a patient in the OP. Today was my OP day. Actually, this man came to me many years ago. He has had a shuttlecock, cricket ball injury or something like that, and still his vision in that eye is actually he's having high astigmatism in that eye. So it is unrelated to that injury. So I sent him for this topography. So it came with something ectasia. So I told him, you take this and go and meet my cornea man. Our cornea specialist. I don't know much. So it is like that. So, so ophthalmology has become like that.
So we have got a question in the chat box whether it will be a replacement for the indirect ophthalmoscopy. Maybe Vijayalakshmi madam wants to do it for her classic patients.
That is a very, very interesting question. To be very frank with you, in the COVID pandemic, actually nowadays I don't spend much time, struggling to see these patients. So I just tell them, I just have a cursory look and tell them, go up, take this photograph, this thing, and come down. And I see everything and this thing. Therefore, this question I asked in the last Retinal Imaging Congress, which this Vishali Gupta was organized, the Rishi conference. I was a panelist. So I asked that speaker from US. I said, now, a patient comes to the retina clinic. So best corrected visual acuity, dilatation, photography, OCT, then see the doctor. So basically, will it become like that?
Yeah.
So, it may happen. It may slowly happen like that. So less and less time. In fact, now how many of the young fellows are doing retinal drawing? We, in our younger days, we used to do retinal drawing and we used to enjoy doing it. And we used to even detect small tears and holes in the periphery in aphakic eyes. But today, how many of these younger people are struggling like that and seeing like that? So slowly, all that basic clinical examination is dying with imaging and other things. Because
The artificial intelligence also comes in, and I
Yeah.
think we will be completely replaced.
No, we will be there to treat. We'll be there to treat.
Hopefully.
Yeah.
We'll be there to
Sir,
treat.
it was a really, even for me, non-retina person also, it was very, very informative. Convincing, rather. I just wanted to know, you discussed in that meeting, what was the consensus then?
No, they all laughed. They had a nice hearty laugh, and they said, yes, it's a possibility. We can't say no.
Only possibility.
Yeah.
Okay.
It's only a possibility. Yeah.
So is it the changing phase of ophthalmic practice that you actually wanted to talk about?
No, I was not planning to talk about that. Actually, I was just looking into, one is, just like, today, if you want to find a good general physician, you are not able to find a good general physician. So ophthalmology is usually going into, so much of a subspecialty area. So a general ophthalmologist is a cataract surgeon. So he sits in the OP and he is only seeing, he is only sitting there looking for cataracts. He is only sitting there looking for cataracts. So basically, in my younger days, I have done refraction, I have done prescribed glasses, I've done everything. So basically, the whole, it's so the changing concept of ophthalmic practice and what it is likely to be 10 years or 15 years from now. So that was actually what I was looking into. And the younger generation, I feel, and of course, I wanted to also talk about. See, I always say that, you have to, it's like our profession is like building a house. It is like brick by brick, But nowadays, I feel that, the younger generation don't have the patience and perseverance to pursue that sort of a ladder. They want things to happen very fast. So, our concept is, patient care. So, I'm seeing now so many people are coming to work with me. So, patient care is the most important. There is a commitment with the patient. That you develop some sort of a bondage with the patient. So, but then I feel that concept is really disappearing. This I'm seeing not only in our ophthalmology, but I think in general in medical practice, because you take your parents to the elderly people to hospital, etc. So basically, that feeling for the person is slowly disappearing. So probably that is all because of our medical education system, where probably we are not really giving that much of impetus and importance for all these things. And so I think these things are going to have a phenomenal impact as far as practice is concerned. So that's how. See, in our practice, when a patient comes to you, you want that patient to come back to you. That's the thing, So that's the main concept, that the patient should come back to you, and that patient slowly will bring another 2 patients. So that is the concept and the way it goes. So basically, but then I think, those sort of, philosophies and ideas, I think, are not really applicable in today's situation. So, and the individual practice, I think, is slowly dying. I think so. I think it is going to be purely eye hospital based practice. Individual practice may be there. We may have small hospitals with one doctor and this thing, but then slowly he will realize he will need another person with him. So basically, so that concept of one person sitting and this thing, I think, will also. It will be there in peripheral areas, in smaller places. Definitely, it may be there, but to a large extent, I think it is going to be a group type of a venture. There may be one employee and one employer and 3 employees, or 4 people who are working together on a partnership basis or whatever. So,
But we are also getting so much addicted to this high-end machines also.
Yeah. That is necessary, because unfortunately, I mean, we have to decide what you want. Now, for example, now we have got this 3D surgical this thing. Many of us have not yet got it, because basically, I mean, of course, when we get it, probably we will get addicted to that also. But then we have not got it because we feel that it may not make that much of a difference. Like intraoperative OCT, I don't think has really caught up. Because even recently in one of the meetings where I was a panelist, there was a talk about intraoperative OCT, and the two speakers themselves in the end agreed that probably there are a lot of weaknesses and lacunae in that. So some of the new technologies are still not very established, and probably it will take some time. But many of the investigative techniques, I think, have become very necessary. I mean, basically, especially in the practice.
I think it is affecting all fields. One of the family medicine doctors, our classmate who came from the US, they were saying if a patient comes with an acute abdomen to the casualty, they will do all investigations. And before touching the abdomen, the doctor will be seeing all these images only. So, so that change is coming in all fields.
All fields, yeah. So any other question?
Divya, there's one question in the chat box.
Sir, yeah, there is a question,
that's a good question. I mean, can we see? Yes, we can see. After zooming the ultra-wide field imaging, even microaneurysms can be seen. Yeah, microaneurysms can be seen.
Sir, can you elaborate on some other retinal disorders apart from diabetic retinopathy for ultra-wide field, like uveitis?
Peripheral, uveitis, it is very useful, especially in vasculitis and all. It's very useful both for photography and for angiography. Then peripheral diseases like Coats disease, FEVR, all these sort of diseases, it's very, very useful both in, in diagnosis and management. Actually, in FEVR and all, after the lasers given, you can take another photograph and see whether you really covered the whole of the ischemic area. It is very useful even in patients with coming with, peripheral retinal pre-detachment lesions like lattice and horseshoe tears, etc. For documentation and patient education, even retinal detachment, it is very useful. The patient comes, you take a picture, you can call the parent, and then he comes back, you say, you just see the tear, you see the detached retina, he is able to understand things much better. Then in retina practice, post-surgically, it is very useful because after doing diabetic retinopathy surgery, you show the pre-operative photograph and the post-operative photograph, and the patient may be seeing only 1 meter. But then you see how many things were there. Now you see everything has gone. So at least the patient is convinced that yes, at least a doctor has done all this and everything looks okay. And so that way, that's also very useful. So peripheral disease, retinal diseases, Coats, FEVR, then all vascular occlusions, uveitis. So a lot of applications are there in this thing. And sometimes, recently actually we had a patient with Mahesh's patient with exudative retinal detachment. So he just took a picture and then, he could in the periphery, he saw a large, actually it was a atypical CSR. There was a large RP rip which he could detect in the autofluorescence, wide field autofluorescence in the same machine. So a lot of applications are there.
Even in diabetic retinopathy, we used to, even before the coming of ultra-wide angiography, we used to treat many cases up to periphery when they are not responding. And I had seen in one of the conference, there was an argument, somebody was questioning why you should treat in the periphery in diabetic retinopathy. So
and
we
I think
have an evidence.
And I think in patients, especially, with suspicious carotid occlusive disease, and these are the sort of patients, I think, where the peripheral ischemic element may be more common. Because those are the patients who have the silent retinopathy, more or less, featureless retina with a pale disc, but the ischemic retina. So the retina may be ischemic up to the periphery. And these are the patients who are likely to go into NVG. Another application is that in patients who have undergone PDR surgery, who are coming with recurrent hemorrhage, you can do a wide field angiogram to see whether there is still persistent peripheral ischemia, which is not yet covered with laser. That's another application you can do.
So thank you, sir, for opening our eyes.
Right, sir. Nice meeting you all, and thank you very much for your. I enjoyed it. So after a long time, I'm giving a talk. Anyway, okay. Nice.
So we have an official vote of thanks by Dr. Dahlia. Before that, I'll just, we used to conduct a weekly quiz. So I just need to put out the answer for the last quiz. Please bear with us for 2 minutes.
Okay.
My slides are visible?
No, Sujit. It's just
Coming.
showing. Now it has come.
No, it's not visible for me. Okay. So this time we had a little a different type of quiz this time. So it was a crossword answers, a crossword puzzle, and the answers. This was the question. It's a crossword. I'm putting out the answers here. So we didn't expect so many answers this time, and many people have actually got it right. We have acknowledged this time we didn't go for the fastest finger first. So we have acknowledged all who have got it right. And thank you, Farzana, for taking effort for making this crossword. Thank you very much. May I invite Dr. Dahlia for the official vote?
Thank you, Dr. Sujit. I think we all agree today we had a very fruitful session with actually a very good insight to the latest technological advancement in retinal imaging, the ultra-wide imaging, and lots of words of wisdom also from sir. So first of all, I would like to thank Dr. Giridhar sir for giving us such an elaborate talk and taking time out for sharing his vast experience. Thank you, sir. Thank you so much. I also would like to thank our chairperson, Dr. Prakash sir, and our moderator, Dr. Divya Nair, for moderating the session and giving us an interesting discussion. Thank you, Dr. Prakash and Dr. Divya. Also, I would like to thank Dr. Vijayalakshmi, our KOS president, and our energetic secretary, Dr. Sujit, for planning and organizing such a useful session for the benefit of all the KOS members. I also want to thank all our KOS members, including our senior members who have taken interest and been part of this session. Thank you all. Last but not the least, I would like to thank our sponsors, Evista Sun Pharma, for their logistic support. Thank you, and thank you all.
Okay, good night.
Good night.
Thank you, sir. Thank you.
Thank you.
Thank you all.